Good afternoon, chairpersons, and I thank you to the organizers of this conference for inviting us for a lecture. I hope after this session nobody gets a headache, and after Sumter's lunch, I hope I don't make you sleep. Headache. So how seriously should we take them? All of us during our lifetime get a headache once in our life. It's no one in the life that doesn't have a headache. Either it is stress-induced or whatever it is, but headache is the commonest symptom in every OPD, including cardiologists, neurologists, and even with family physicians. You people come across headaches daily, day in and day out. And sometimes patients give you headache and they go away. And then you say, okay, go ahead. So headaches are of different varieties. Some can be ignored, but some of them have grave significance. So what are of grave significance, that is more important to note, and what can be ignored is easier to go about. So in any symptomatology, what we come across is that the main things that we should not leave about is the history. The history is the most important part in headache. So the onset time, the characteristic, and then followed by the associated symptoms. So a patient, young patient coming to our OPD during exam time. Now the boards are approaching. So in Gujarat and Central Board, we'll get plenty of students appearing in boards coming with even acute onset headache. So whether it is stress-induced, exam headache or something else. So that has to be differentiated with history itself. You don't need a CT scan or an MRI every time, and you don't need us as an experts to differentiate it. So primarily, if we get define, the most commonest type of headache which we get is a migrainous type of headache. In primary type of headaches, primary means in which there is no structural lesion. And in primary headaches, the most commonest is migraine, followed by a tension type headache, then a cluster, and then different varieties of other primary headaches, which are autonomic cephalgias. In secondary headache, headaches which you get after something, that is trauma to the neck or head, cranial or craniovascular disorders, non-vascular intracranial disorders, substance abuse or withdrawal abuse, infections, disorders of hemostasis, and some psychiatric disorders. Prior, my speaker and friend Dr. Rajan had a highlight that anticoagulation. Anticoagulation in valvular heart disease is common, and that may lead to acute onset headache in which there is an intracranial hemorrhage. And then we classify others like cranial neuralgias, central causes of facial pain, and other type of headaches. The most common headaches is migraine and tension type. So what is tension? It is not that we tie a rope to the neck and then we get a headache. No. Tension type headache is a headache in which the patient has a unilateral, throbbing, spastic, muscular pain on one side or diffuse part of the brain, and it is never associated with vomiting. It may be associated with nausea, but never with vomiting. And it is sharp shooting and throbbing, but there is a muscle spasm. So how do you differentiate with the migraine? Migraine, it may be preceding with an aura or without an aura. What do you mean by aura is the preceding symptoms prior to getting a headache. Sometimes the patient feel a abnormal smell or abnormal sensory symptoms or an abnormal visual or an auditory horror. Some patients complain कि भी sir एकदम आँख के आगे तारे दिखने लगते हैं, white. And some patients, they do complain that we get some abnormal sounds in the ear. And after that they get this unilateral or a diffuse headache, which is usually associated with nausea, vomiting, and then after vomiting about 50% of the headache gets relieved. But in 50% of cases, the headache may get aggravated after the vomiting, and the patient pain may increase in severity, and the pain score may worsen. So in this, the migraine is then, it's either a hemicranial migraine or a diffuse migraine, and migraines can also be with aura or without aura. So now we come to the classification of migraine. In classification, migraine without aura, probable migraine without aura, migraine with aura, childhood periodic syndromes, retinal migraine, complicated migraine. I would like to just highlight in this that migraine is the most common type of headache which we see. in our OPD and in family physicians OPD also. But why it is important to declassify migraine is because the treatment part is different. If you give treatment in both the migraine, all migraines is not the same. So we have to differentiate in which type of migraine it is, and declassification is required. Migraine is also very common in children, but it is classified into childhood periodic type of syndromes and a retinal migraine. What is retinal migraine? Retinal migraine is a migraine which usually doesn't involve the retinal membrane, but it is other name was ophthalmologic migraine, in which the pain starts retroorbital and radiates to the whole of the brain, and it is usually associated with visual symptoms predominantly, but it is never associated with nausea or vomiting. And what I mean by what is complicated migraine? Complicated migraine is headaches in which usually you get hemi symptoms like hemisensory loss or heavy motor loss or a facial deviation during the episode of headache, in which it's a complicated migraine. And complicated migraines can be a precursor to future strokes or a future retinal disclosures. It is one of the most, migraine is one of the most common complaints, a common pain seen in family practice. Half of the migraine patients stop seeking treatment because headaches don't go away. And many migrainists report significant disability and reduction in their QOL scores. Therefore, it is appropriate for all of us to consider prevention of these patients who has substantial impact in life. The migraine onset can be at any age. Family history of migraine is present in around 90% of cases. So in history, you have to always ask whether your mother, father, sister, maternal or paternal history is very important. It tends to recover with varying frequency. Sometimes spontaneously it goes away. Normally in females, we see that majority of females during menses get severe migrainous attacks. So we ask them, okay, once your menses goes away or you enter into a postmenopausal phase, the chances of you getting spontaneously recover from migraine are more than 50%. But still, 50% of females, the worsening of the headache also happens. So it is also hormonal imbalance. And these headaches tend to recover with varying frequency throughout life, and attacks tend to get milder and less frequent in later years. What is the basic pathogenesis of migrainous headaches? It can originate from peripheral or central. Peripheral, it is basically gets activated from the trigeminal autonomic nerves, because the trigeminal nerves covers the whole skin of our brain and the face, and then it releases the vasoactive factors from the blood vessels, which leads to vasodilation. So the peripheral vasodilation and also the central vasodilation, these are the basic pathogenesis which is now being hypothesized, but it's still the exact pathology or pathogenesis of migraine is still not known. We just proposed, it's a proposed hypothesis that there is a vasodilation of these vessels which leads to dilatation, and then it is an automatic activation of the vasoactive proteins which leads to pain and the release of substance P, which causes severe headache. Regardless of the source or signaling, common mechanism of headache is dilatation of the large cranial vessels beneath the dura mater. So the cranial vessels are predominantly innervated by trigeminal nerve and form a part of trigeminal vascular system. And these are the vasoactive peptides which in turn lead to headaches. The prevalence of migraine, it is very prevalent in India. The prevalence of migraine is increasing in India because of our lifestyle. Now, the most important slide of my topic, when to refer the patient or when to investigate the patient. The most important part is the headache. The migraine patients comes to you almost monthly. The most important question to ask to that patient who is already suffering from migraine is whether there is a change in the character of the headache. Any change in the character of the headache or severity of the headache of that particular patient, because the patient comes to you first. And if you find, no, this headache is not as it was last time, that is a red flag. Red flag means you need to refer the patient or you need to investigate the patient. Any headache associated with even transient altered sensorium or unconsciousness has to be investigated. It cannot be ignored. Even though you think it is psychological, plus please do not ignore it. Any headache associated with altered behavior for even a transient of seconds, if the patient has irrelevant talking with headache, or if you suspect that the patient had uprolling of eyeballs or tonic movements, or he was not answering the questions at home properly to the relatives, it may be a probable sensory seizure. So any type of convergence, whether it is a motor phenomenon or the sensory phenomenon, it's again a red flag for us. Any kind of weakness anywhere in the body, headache associated with slurring of speech, facial deviation, eye deviation, hand weakness, sensory numbness, either in the hands or toes or in the fingers, has to be investigated further. Any headache associated with blurring of vision or headache followed by blurring of vision needs to be investigated, and headache with protectile vomiting should not be ignored, because these red flags can be because of brain tumors, hemorrhage or aneurysms. This is a young girl who was appearing for the board exams, and all of a sudden got a headache during the exam, and then she had protectable vomiting. So she was first referred to the physician available in the school, who gave him antiemetics, no relief, but the headache worsened. And as soon as the patient reached home, she became unconscious. So this girl had a cortical venous sinus thrombosis, which is treatable if treated on time. This is a tumor in the frontal part of the brain, which is a meningioma. Again, this was a migrainous patient who had worsening of the headache and was associated with intractable vomiting and along with facial deviation and transient slurring of speech. So what is the treatment of the headache? Again, after we have seen the types of headache, and so this, how do you treat a migrainous patient, and when does a migrainous patient needs treatment? So we divide treatment into acute phase and the prophylactic phase. And the successful treatment of acute migraine attacks is defined as combination of either one or the combination of all of them. Pain-free as early as 2 hours of the onset of headache. Decrease in severity of headache in pain scale from VAS from 10 to less than 5 in 2 hours. And consistent efficacy in 2 or more attacks. And there is no recurrence or no further treatment is required for next 24 hours after the successful treatment. So how do you treat an acute attack? Either with acetylsalicylic acid, ibuprofen, naproxen, diclofenac, paracetamol and tolfenamic acid. These are analgesics and these are triptans. Triptans are specifically meant for migrainous headache. We have to remember the contraindications for them, that it should be used with caution in patients suffering from ischemic heart disease or who had a prior history of stroke, elderly patients with history of renal failure, and in females who are pregnant or lactating females.
So 1 minute, please.
Yes, sir. Antiemetics. It can be given in combination with analgesics. Nowadays, naproxen with domperidone combination is available. And in severe headache, in migrainous, which is known as status migrainous, which lasts for more than 2 hours and in which the primary treatment doesn't work, then we use antiepileptics such as sodium valproates, magnesium or levetiracetam. Now, when to give prophylactic treatment? The prophylactic treatment of migraine should be given as per IHS classification only if the patient is suffering from headache or the headache episodes are more than once a week or 4 episodes in 1 month. That is criteria number 1. Criteria number 2, if the headache severity is incapacitating or decreasing the quality of life of that particular patient. Number 3, it is affecting his routine work. And lastly, it is disabling him for more than 4 hours in a day. And in prophylaxis, we can use antiepileptics, calcium channel blockers, beta blockers, and a whole range of drugs. Lastly, I would just take only 1 or 2 slides for medication overuse headache, which is nowadays everybody is Googling. Patient comes to us after taking the medicines. So headache which is present for more than 15 days a month, regular overuse of that particular drug is there for more than 3 months, and in this it can be triptans, it can be opioids, it can be any analgesics, or it can be a combination of all the time. And headache has developed and markedly worsened during the medication overuse. This is known as medication overuse headaches, which is nowadays we are seeing them because patients take a lot of analgesics and come to us. And the treatment is basically you need to educate the patient, gradual withdrawal of the medicines, and acute treatment can be given with after admission or without admission. And with, in this during phase for 5 to 7 days, we may use a high dose of steroids to prevent withdrawal symptoms. Thank you.
Thank you, Dr. Jitender Singh. You have narrated very well about the headache. Now, there is no quiz after this session, but I request in your slides, please show the red flag. Red flag. As you all, we are treating headache quite frequently. So, in these red flags, one thing is remained. Can anyone say? In our family practice, we quite often see headache patient. This, if patient is having these symptoms, then it is important that we have to refer. But is there anything else? No, subarachnoid hemorrhage, patient is, it's a diagnosis and patient will have this, one of these symptoms. But headache, remember, Dr. Jitender Singh will also accept. Headache, which is severe and happened for the first time. Happened for the first time. Those patients who are having headache frequently, they are sometimes not so serious. But a person who came for the first time with severe headache, without these symptoms may appear later on. But patient comes with you for the first time and have tell that I am having severe headache. This type of patient require sometimes reference, and it may turn out to be some serious disease. Is there?
Very true. Irrespective of the age, irrespective of the blood pressure or the hemodynamic status, acute headache, diffuse or unilateral, presenting for the first time in his life, without even associated red flags, should not be labeled as migraine on the first day itself. It can be diagnosed properly.
Dr. Singh will give memento to Dr. Jitender Singh. Next session chairperson is Dr. Vinod Patel.